everybody. I hope everyone is here. I can take my note taker out. I don't need my otter taking notes here. So I think we should be able to see when people join. Oh, we have 13, 15. Hello, everybody. Welcome, welcome. We'll give everybody a minute or two to log in, and then we get to introduce these three awesome people. And just to get started, could those of you who are here, if anyone has a person with diabetes in their family, could you put a yes in the chat so we can see the chat working? I can put a yes in the chat. Yes. Someone text us something so we can just see if that's working. I just want to make sure that your messages are working. So we're going to get started in about a minute, and I'm going to be excited to introduce two amazing endocrinologists that we've been working with. Well, Denise, we've been working with for a long time. And a really fun surprise for me tonight is that I get to introduce Dr. Sarah Tarek, who is the newest NVFP physician. And welcome, Sarah. We're super happy to have you. Sarah has been the Dean of Medical Students in University of Arkansas Medical School for how long?
A long time. I was at UMS for 22 years.
22 years. So we're so glad to have someone who is like a just rock solid academic and amazing in medicine. So Sarah, could you just tell us a little bit about what you're interested in and just your kind of first couple of days here at NVFP and what you're interested in, and then we'll go around and introduce Denise and Ramona.
Absolutely. Thank you all for having me. It's a pleasure to be here. I am the newbie at Northern Virginia Family Practice, and I'm honored to be part of this amazing group of folks. My areas of interest really are in women's health. Of course, I do a lot of work with type 2 diabetes, hypertension. My main focus tends to be really lifestyle management, preventive health. I'm also an executive coach, so I love to use my coaching hat as I help my patients sort of empower them to make decisions about their lives, to talk about the balance of lifestyle and what you're putting in your body and your activities and your sleep and your mental health and your mindset. And so I really appreciate being able to share my thoughts about holistic care and really the whole person. And so I'm really happy to be here. This is my third week at Northern Virginia Family Practice. I am in the Washington, D.C. office on M Street, and I'm really enjoying my transition to this group. So thank you for having me.
Yeah, you're welcome. Welcome, welcome. And thank you for telling me the chat is disabled. And someone here is raising their hand and say, yes, they have type 1 diabetes. I'm going to try to enable the chat. And while I do that, Denise, could you introduce yourself? Denise is a wonderful endocrinologist we've been collaborating with for years. And she started what I think was the very first concierge endocrinology practice that I know of, let's say, certainly in the DC metro area, maybe somewhere in the country. She was also the first. So go ahead, Denise, and give us a little 2 cents about you.
Well, first of all, thank you so much for the invitation. I think it's a pleasure. I've been knowing Natasha for many, many years, and more so in the transition of my practice to a traditional practice to concierge. And we have built a very meaningful relationship through the years, and for sure collaboration in all aspects. I'm originally from Venezuela, and I did my med school in Venezuela and came to the US, did a little bit of research at the University of Michigan in neuroscience, and then did my residence in internal medicine in New York, and then moved to University of Miami. Actually, we have the big diabetes research institute there. They do a lot of these trials for type 1 and type 2, and they do islet cell transplant as well. And I stayed there as an attending for a few years. And then I moved to the area in 2011, and I opened my own practice, and I've been here since then.
Thank you. Yeah, she's been so helpful for all of us. And then maybe Denise, introduce Ramona since she's the newest person here.
So Ramon, I met maybe over a year ago, or maybe a little bit longer. I met her one time way before, and then we just started to connect again maybe a year ago, and we started talking. And she was in the traditional practice of medicine, in and out, and she felt like our field, there's a huge need to be spending more time with patients. She focused a lot on lifestyle changes, and she wants to address every aspect of medicine, especially endocrinology, when everything is connected. And she just decided to join me, and I'm very happy to have her, but she can tell you a little bit about her background.
Yeah, absolutely. So thank you so much for having me this evening. I'm excited to talk to all of you. And so, yes, so I did my residency at Cornell in New York, and then I did my fellowship at Mount Sinai, and then I moved to Northern Virginia about 8 years ago. And since then, I've been working in, sort of the traditional model of practice, and then joined Denise about a month ago now, or maybe close to 2 months at this point. And yeah, so far, it's been great. I really am happy to be part of this sort of concierge model where I can really just take time and spend with patients and help them focus on, all parts of their endocrine care, but all parts of their, medical care, and just make sure that, we're addressing everything. So I think it's really been a great transition for me, and I'm enjoying it so far.
So happy to meet you and really nice to talk to you here tonight.
Thanks.
Do you say Sachi or Sachi?
Sachi.
Sachi. Okay, so we're all talking in first name basis, but this is Dr. Sachi. So the chat's now working, and if you have any questions throughout anything that we're just chatting about, please type them in so we can work on them. We would love to hear anything that you're interested in learning. We wanted to do a little bit of a foundational discussion about some really fundamentals of diabetes. Sarah, do you want to kind of introduce a topic or two?
Sure. As sort of, I'm really sort of passionate about this topic, not only as a primary care doctor, but as a mom of a kid who has type 1 diabetes, who's an adult, and parents who are both type 2 diabetics. And a question that a lot of patients ask me is around what the hemoglobin A1C means. We all of us who manage diabetics, that's really sort of the holy grail that we really follow, and we talk about it a lot. And so patients sometimes say, what exactly does this mean? How often do I have to get it checked? And what is this goal that people talk about? And so I'd love to bring that series of questions to our experts.
Yeah, that's a great question. So a hemoglobin A1C is a measure, it's a blood test that helps to measure your blood sugar on average over 3 months. So it's looking actually at the glucose or the sugar that's attached to your hemoglobin, which are your blood cells, and it gives us an idea of how high, low, or normal the blood sugars have been over that course of time. We generally recommend a 3-month interval for checking these tests. So that's typically what we do and what insurance covers. So that also dictates it, testing as well at times. And then goals. So the American Diabetes Association recommends at least under 7%. So that's generally what we say. And then, we do focus for different groups on different goals. So we do individualize this. So for older patients, we might say, well, that goal does not fit with their needs. They may have the need to have a higher goal because low blood sugars may be dangerous, or someone who's maybe interested in pregnancy, we might aim for an A1C that's under 6.5%. So it really depends on the patient, but I would say in general, for most sort of the the goal that captures most patients is under 7%.
Got it. Thank you for that, Dr. Sachi. How about another question that I commonly get a lot is how people are interested in the technology. And it's been a huge blessing that we have, now we have continuous glucose monitors that are accessible for a lot of our patients. Of course, all of our patients with type 1 diabetes, and for a significant growing percentage of patients with type 2 diabetes. Could either one of you comment on the CGMs? I think it might be it's a little overwhelming for people, but really sort of talking about what's the use of it, how can it be helpful, and how accessible is it in general?
So a continuous glucose monitor called CGM has been in the market for a long time, at least since 2010, 2011. And they have the first one actually was with Medtronic, the iPro, and then Dexcom came. And since then, there's been different models of Dexcom. Right now it's G7, and then we have the third one, that it's intended to use for patients with diabetes. Because there's a new one, Stella, which is part of Dexcom company, but it's for patients without diabetes, and that's over the counter. And then you can order that through their website, and I think it's about $70 per either per month or per sensor. I can't remember exactly, but you can get it in the regular pharmacies. And this Stella, the new one, it's intended for patients who have prediabetes, because insurance does not cover CGM for patients who have prediabetes. It's covered for type 2, and they have to be at least on 1 insulin injection a day. It used to be 4, and it's covered for, of course, type 1. So the beauty of this continuous glucose monitor is that measures interstitial glucose. So you can get a real reading of your glucose levels. If it's Dexcom, it's every 5 minutes. If it's the Freestyle Libre, it's every minute. And you can see patterns or trends. So when you wear the CGM, for example, Dexcom, you change it every 10 days. The Freestyle Libre is every 14 days. You connect to an application through Bluetooth in your phone, so you can see the tracing. So as you're eating, you can see how your sugar starts trending up, and then they come down. So you can actually see the real effects on certain food on your glucose levels. And sometimes that can help you determine, okay, maybe next time I'm going to have less of these type of food that is raising my sugars too much. So I think it just changed behavior some patients because they're aware of it. As we know, diabetes is kind of a silent disease for type 2. For type 1, it's a little bit different. Usually, if the sugar is above 180, 200, sometimes that's a pretty high number, and patients don't necessarily feel it. For type 1, it's a little bit different. They do tend to have more symptoms of type 2. So I think having a continuous glucose monitor that you can put on your arm, on your belly, and there's different indications depending on the device you're using. It can lead to different options of food that you eat, or maybe adjusting insulin dose. And I think it's a learning. They have done many studies showing that patients who have used CGMs, A1C has significantly been reduced over time as opposed to not using CGMs. So I think it's a great tool, and I do recommend to all my patients. And I'm very happy that now we can recommend to prediabetes, because it really can make these patients in the pre-diabetic range restore to normal range or close to normal with just a CGM and no need to be on medication. So it's a great tool, and it's available. Most of insurance do cover. And some of these CGMs are integrated with insulin pumps, which is another different topic, but it's great for patients with type 1 because it just gets the patient in the tight control range that we want to. And a few other things to say real quick is that the continuous glucose monitor, as doctors, we get a report. And in the report, we see like a bar that is red, and that's when the sugars are very low. So you get like a very low glucose percentage. Then you get a low number, which is less than 70, and then you get time in range. The time in range is the green bar, should be between 70 and 180. And then you get the yellow bar, which is between 180 and 250, and the very high, which is above 250. So ideally, the time in range should be around 70 to 180, and that includes pre and post meal, which is what A1C is, the average of the sugar for the past 3 months pre and post meal. And these patients can see how well they're doing. In fact, most of the endocrine associations are now going towards a goal of not A1C, because A1C can be falsely changed by if the patient has anemia or has some sort of thalassemia. So A1C sometimes is not as reliable. That's what we have. But CGM is a little bit more reliable when you have this time in range, and when you see the fluctuations on the glucose not being so high or low, Because sometimes you can have very low blood sugars or very high blood sugars, and the average is A1C of 7, and that's not ideal. So it's just to be in the time range that is ideal. So if the time range is 70%, then that's a good target and reduces risk for complications.
I'm so glad to hear about the Stella thing because I mean, I have patients with type 2 diabetes who don't get approved for CGMs because they're not on insulin.
Right.
And I still want to give them that visibility. So is that the best way to do that?
Or you can use savings cards. What is the name? There's a savings card that you can use for like Freestyle Libre that is also cheaper. I forgot the name of the company, but it's a code that you can get. I'll find it. That you can get, and
if you add it later, we can put it in the notes for this. So once we post it on our website, we'll add it with our notes. That we can add a list of resources for patients. Like we can add about the Stella, and we can add whatever that code is. Could you also talk about? And I'm not sure if this happens with the ones that you get by yourself online, but sometimes they're registered to alert when the blood sugar goes under 60, and then people are just asleep and their blood sugar goes under 58 and they get woken up all the time.
So, Dr.
Yeah. So, I mean, they basically have, as you're setting up these devices, they have set ranges. And so you can alter, like for the Stelo, for instance, I'm actually wearing it now, I'm testing it out. So, they do have ranges you can alter in there when you're setting up the app. And you can, at least in the Stelo, you can set up certain notifications, the Libre as well. So you can sort of dictate, whether you want things to alert or not. I mean, obviously in our patients who are at risk for hypoglycemia or low blood sugar, less than 70, we want them to know, right? We want this to wake them up. So it really depends on the patient. If we're talking about a patient who doesn't have diabetes, maybe has pre-diabetes, is not on medications that might put them at risk for a low blood sugar, then yeah, they obviously may not want to wake up or, get these sort of alerts because it just may be normal for them to have these blood sugars in the 60s or 70s. They have no symptoms. They're not actually, it's not actually clinically significant. Then certainly, they don't need those alerts. So yeah, so some of them, yes, you can turn them off, but it just depends on what the purpose is.
Make of patients who have morning fasting glucose like in the low 100s, like 108, 110, and their A1Cs are fine. Like like super fine, like 5.4.
So is your question why they would have a high, fast? It just depends, right? Because if you look at an A1C is an average. So this is just an average over the entire day. So if their average is still, keeping them at that A1C of under 5.4% or under 5.5 or whatever it is, then yeah, absolutely. You can see higher numbers. Some people can have higher blood sugars in the morning, and that can be for a variety of reasons, whether they snore and maybe there's a rise in the sugars because of sleep apnea that's untreated, or maybe they have higher numbers at night because they, we know that in the early morning, there's a rise in certain hormones that causes a rise in blood sugars. So some people have more of a dramatic effect and maybe that's it. So, yeah, absolutely. And there are patients like on the flip side, right, who their A1C comes back at 5.7%, which is pre-diabetes. But they have their fasting blood sugar on maybe one of their blood tests. It's normal and it's always normal. So they're surprised. They say, well, my blood sugar is always normal on these tests that I get in the office, but why is my A1C high? And that's because the numbers that aren't being captured later in the day might be higher, and that's contributing to that high average. So it just, it depends on what that sum of the numbers is. And obviously we're not capturing all of that.
But I think sometimes that you can get impaired fasting glucose having a normal A1C, and that could be also the beginning of pre-diabetes, right? So these patients start having excess production of glucose at the level of the liver in a fasting state, because if they're not eating, it has to be coming from the body, and maybe they have hyperinsulinemia, not enough insulin or they do have insulin actually, but it's not effective enough lowering that number. And so you have to look at genetics too, right? If they have strong family history of diabetes, they may be at risk. If they have history of PCOS or polycystic ovarian syndrome, they may have more risk. So you have to look at the whole context of the history of the patient. to say, okay, do I need to be aggressive here or not? And I'm not talking about aggressive being treating with medications, but maybe be more aggressive with lifestyle changes. That would be a perfect patient to put on CGM to see what are the numbers pre-meals and the numbers post-meal, like as a trial for 14 days. And then you can see a lot of data there saying, you know what? You have to cut down on certain type of food that is making your numbers go like this, and then it works. So, or it could be that years ago, the cutoff for fasting sugar is 110. And then they changed the cutoff to 100. So you have a subset of patients that have these sugar between 100 and 110, which may be normal for them because they have a perfect normal A1C, no family history. And, you know, you have to consider that too. There's a subset of patients that are a little bit outside the norm of what's normal, and that's not necessarily abnormal. It's like patients who have a little bit of low white blood cell count, but it's chronic neutropenia, stable forever, that's them. So it really depends on the history that you get, family history, personal history, risk factors.
Denise, speaking of, about what you're eating and what we're putting in our bodies, and I think the messaging that we get from the commercials and from at the supermarket is so overwhelming in terms of carbs. And then we go to nutritionists and they tell us different things. What are your are there general guidelines that you all use as you advise your type 1 or type 2 diabetics in terms of how much carb is really healthy for a diabetic? You know, there's all the keto and all of these fads and things out there, but really when we're talking about the evidence and what's really best for the patient, what are your guidelines or what are your recommendations in terms of carbs?
So the American Diabetes Association usually recommends 60 grams per meal, but I take that with a grain of salt. Okay. Because not everybody needs to do 60 grams per meal. Okay. That's for type 2, talking about type 2. I mean, type 1 is a different disease, right? Type 1, they do not produce insulin. They have an autoimmune destruction of the cells that produce insulin, and they lack of insulin production. So as long as they inject insulin for the amount of carbs they eat, starchy carbs, then that's fine. Of course, if they're overweight, because there's some type 1 that tend to be overweight, I would watch the carb intake too. But ideally, it depends. If the patient has a diabetes with an A1C of 9, I'm not going to tell them to do 60 grams per meal. So I'm going to try to reduce the amount, but of course I do recommend to have some carbs. So I would just try to say, like, you know, if you have a plate, half of the plate should be non-starchy vegetables, either salads, broccoli, cauliflower, you know, like the green fresh vegetables. The other half, you divide it in two and do protein. So I think protein is very important. And then you can do a little bit of starch, but instead of doing a cup of rice, you can do half cup of rice. And you don't have to do that all the time, right? But just an idea. I think there's so much misinformation, and I think that the food labels are very confusing because they say fat-free, carb-free, and you look at the label and you have, well, we teach the patients to look at the label, total carbohydrate amount per portion serving size, right? So you can have like something that has 3 serving size, and each serving size is 19 grams of carbs. So the patient gets confused saying, oh, the whole thing is 19 grams. No, it's not. And so I think, you know, we do send to certified diabetes education for that reason, because there's a lot into that and there's a lot of misinformation out there. So we complement that with referring the patients for certified diabetes education while we're in the office too, and recommend what, you know, we think is best for patient. But we tend to individualize, you know, the amount of carbs we recommend for patients.
So that's a perfect example of misreading the label. So like, it almost went even too fast for me, so I'm just going to restate it. I think what you're saying is you pick up a package, it says there's 15 grams of carbs in it, and it's easily edible in one setting. And then you don't realize there's actually 3 or 4 servings in the bag. Is that what you're saying?
Correct.
Yeah. So what are some of the other like really common misunderstandings that people come in with? Or that you realize after you start getting really a detailed history? What are like the top few?
So they think they cannot eat fruits because fruits have carbohydrates, and I am very happy with them eating fruits as healthy carbohydrates. So I'd rather have them eat an apple, which has a good amount of fiber. It's only 15 grams of carb, like a medium to small size, than to have a piece of cake, for example, right? I mean, what other things, Dr. Sachi, do you?
Yeah, I mean, I think just, commonly patients will not realize on the flip side of that, that things like oatmeal, they hear oatmeal is healthy and they don't realize that, yes, it does. Some oatmeals tend to have high fiber, but they also can really have a high glycemic index, meaning when you eat them, the blood sugars can spike quite a bit. So, there's some foods, and breakfast is really that tough meal to figure out how to minimize the processed carbs because that tends to be what's popular. But I think there are a lot of foods where patients don't realize, oh, I've been eating this healthy cereal or I've been eating this oatmeal and I thought this was great for my blood sugar. And especially once they have that CGM on, they see, oh my gosh, I ate that and now my blood sugar was through the roof after that meal. And so I think they learn that those meals actually can make the blood sugar quite high. And so I think one thing that we try to focus on is making sure patients understand, number one, focusing on protein and fiber-rich foods tend to be things like those non-starchy vegetables and things of that nature. So really focusing the meals on those two things will help minimize the carbohydrates and hopefully, the downstream effect of the higher blood sugars after eating it. So that's just one thing that, comes to mind that patients are like, oh, I have a great breakfast. And I'm like, oh no, your blood sugar's probably high after.
I would add to that, I really like second and third the fruit question because that comes all the time. Like, can I eat fruit? I shouldn't eat fruit. And yes, we should all eat fruit. Please eat fruit.
Yeah.
But I'm really glad to hear that that's what your recommendation is as well. And what was my I
And I
forgot my
think
second
also on
point.
the fruit topic too, I tell my patients that not all fruit is created equal, right? Like certain fruits are going to have a higher glycemic index than others. So when you're choosing those fruits, things like berries, raspberries, blackberries, blueberries tend to be a little bit lower glycemic index than when you're comparing to banana, for instance, or mango or watermelon. So, you also want to think about, yes, these are fruits and they're all good, but if you want one that may not cause as much of a spike, you may want to focus on certain fruits and maybe others in moderation.
So, Natasha, it's interesting because there's another misconception that I get asked a lot, and patients say, well, I'm diabetic, I can't eat carbohydrates. And I was like, what? I mean, I had literally patients, even with type 1, that old-fashioned doctors have said, you have to time your meals and you cannot have pasta or potatoes. And literally these patients have not had this for years. I have a patient like that. And I said, but why not enjoy life? I mean, you can have carbohydrates, you have type 1, you just have to inject insulin for that amount, and you don't necessarily have to have these scheduled meals. Maybe that works in the beginning when you first get diagnosed, but then as you get older and get used to the diagnosis, you more or less have you have a sense of, okay, this food is going to raise too much, I'm going to inject a little bit more than not. But for my type 2, I try not to restrict completely the starchy carbs because they're delicious. I mean, I'm going to be honest. I love ice cream. I love chocolate. Why not? But I tell them, look, if you're going to I have a patient, actually, she loves Haagen-Dazs. That's a perfect example. And she buys the pint and she just start eating the whole thing. I said, listen, if you're going to buy the little ones, they're maybe a little more expensive, but then you finish and that's it. That's your portion. And then do it every day. And then you already feel pleased that you had your ice cream, right? Because if not, you wanted more. And so psychological is an effect that I cannot have it, I want to have it. So I do tell my patients, have a little bit of carbs. You go to cheesecake, you cut the cake in 3. A third, you do one day, another third, another day, and the third, another day, and that's okay. So it's more of a balance, right? Because we still have to live life and enjoy. But I also recommend exercise activity because exercise can bring, the glucose levels down significantly. And so if you had a large starchy heavy meal at dinner, go for a walk. Your glucose levels are going to come down. In fact, in type 1 diabetics who are on insulin, I tell them, if you're going to exercise, you have to back down the dose by half or maybe 2, right? So to prevent hypoglycemia. But, exercise is a great tool to lower your sugar levels. And, we just don't do it good enough. I mean, we, as doctors, we recommend, but it's like It's like I feel repeating myself over and over. Are you exercising? How much? And they think, okay, I have to exercise 1 hour every day. No, you just do 20 minutes. 20 minutes, go for a walk. It's okay. You're doing some physical activity or just go up and down the stairs, you know? So I think it's just little tips that patients can do in order to minimize elevated glucose levels.
Right. Agree. And I always tell patients, some exercise is better than nothing. If you're like, I wasn't going to do anything today, if you do 10 minutes, 5 minutes, something to just be in that sort of routine and mindset of exercise, it's really helpful. And I agree. We see all the time patients, blood sugars drop when they exercise because it allows your body to use whatever insulin you have more efficiently because the muscles are using it, and you're also, you need that energy to do that activity. So it really does help, even for hours after that activity, keep the blood sugar stable. So that is a great tip. And then the other tip that I don't know if we mentioned is, the order of in which you eat the food. So eating the protein or fat in the meal first prior to the carbohydrates, also in patients who are either insulin resistant, have diabetes, prediabetes, any of those categories, if they tend to have a spike in their blood sugars after carbohydrates, then eating those things can help blunt that effect, meaning that the blood sugars may not rise quite as high because you've had those other things first. So food order is also actually helpful.
Could you go through the most fundamentals? I just love the graphs about what happens if you eat a starch versus what happens if you eat a protein versus what happens if you eat a fat. Could you talk about how you educate about that?
In terms of blood sugar. So, I mean, I think of course, it depends on the patient, right? So if you don't have any abnormality with insulin, don't have any element of insulin deficiency or insulin resistance, meaning that your body responds normally to when glucose comes into the system and releases insulin to manage that blood sugar, you shouldn't see a whole lot, honestly. So, you'll see that the sugars stay pretty steady regardless of what you're eating for the most part. So that's someone with like perfect glucose metabolism. And that's regardless if you're having the protein, the fat, or the carbs, really. So it really depends on what your degree of insulin resistance is. So now patients who, let's say, have type 1, we see, depending on, again, how much insulin is on board, how much insulin they have in their system, we might see a really dramatic spike in their blood sugar after having a carbohydrate, and that depends on the type of carbohydrate. So now if we're talking about something that we consider processed, like I don't know, anything you find in a packaged carb, you will see a much more sharp rise in the sugar, and it might stay high for longer versus, let's say you have something like a carrot. So carrots have carbohydrates. You might see a bit of a rise, but it's not going to go quite as high of a peak compared to that processed carb, like a processed cookie or something. And you'll see that number will come down a lot faster. So it depends on what it is. When you eat something that has carbs and fat, we'll also see that number will rise. But it's often, or can be in some people, delayed. So because the fat is first being absorbed, the blood sugar doesn't rise right away. Sometimes it can take, up to an hour, 2 hours, even 3 or so hours after first ingesting that meal that has fat and carbs, for you to really see that spike. So, the answer is it depends. So I don't know, Denise, if you have anything to add to that.
I mean, I try to tell the patients, well, exactly, depends on type 1 or type 2, right? Let's talk about type 2. That's the most common form of diabetes. Patients who have insulin resistance, meaning that the insulin that they have may not be working effectively enough, lowering sugar levels, but they still produce insulin, right? So if they eat a starchy carb and 2 hours after a meal, glucose levels rise to 180, that's a little bit too much. So you have to time it if you want to really look, either finger stick or CGM, look at 2 hours later, because you can see a significant spike on the starchy carb an hour later, or 30 minutes starts going really high, and then patients are going to be really concerned. Oh my God, my glucose is really high. But at 2 hours, it's the cutoff that we actually, try to educate the patient. Look, 2 hours after a meal should be ideally, normally it's less than 140, okay? But if it's 140, 160, I'm okay with that. 180, then it's a little bit too much. So maybe you have to consider backing down on the portion size of certain food that could have raised the glucose. If it's 200 250, way too much. And then pre-meal numbers, maybe 100 to 110, because the CGM is not 100%. And so, sometimes patients become a little bit anxious about, oh, my glucose, because they're looking 24/7. And, sometimes it just becomes very intense for them to look at the sugar all the time. So I said, look, this is a tool. What I want you to do is just to look at your pre-meal numbers and then 2 hours post-meal. Don't start looking at it all the time. Of course, you're going to see trends. If the sugar starts going up, you're going to have an alarm on the phone where you have the software that reads the CGM, and it's going to say trending up, trending up. And so then, you have to do something about it. If type 2 and they're not injecting insulin, I would tell them go for a walk to minimize that spike, right? But if it's too late, then I say, well, next time when you're going to have the same meal, reduce the portion of the carbs that you ate. And so that's for mainly type 2. For type 1, then you may need to adjust the insulin, the carb ratio, because as disease progress, patients start with a carb ratio 1 unit for every 30 grams of carbs, and then one in 20, 1 in 15, 1 in 10. So it just changes. And if they're using the pump, now we have very smart pumps, and the pumps have something that can sense with the CGM what the sugar levels have been, and they either, if the sugars are going up, there's an algorithm that they can just pump a little bit more insulin to prevent the spike. It's not perfect, but it does work. And it works most for patients who are getting lost in the middle of the night, so the pump stop delivering insulin. They do have to have a continuous glucose monitor that is linked to the insulin pump. And so it's great because they don't get a lot of low blood sugars in the middle of the night. And if they are trending down, it alerts them, listen, your glucose is going down, do something about it. So I think the range should be maybe 100 to 110 pre-meal, and maybe 2 hours after meal, no more than 180. Ideally, 140 to 160.
I
Yeah.
love
Thank
that
you.
advice about not being so hypervigilant about it.
Just
Yeah,
thinking
I
about
think, I was just gonna say that
Yeah.
sometimes, you're right, that too much data sometimes can be overwhelming, and if it's not helping and it's overwhelming you, then, sometimes it's important to take a step back, and, especially for patients who don't have, who aren't on insulin, not maybe at risk for hypoglycemia, where like we really want you to be on these devices. If you're using it for purposes of, just educating yourself about the rise in numbers, and maybe you're pre-diabetic, I tell them, if you want to do something like the Stello, for instance, maybe you do that just for 2 weeks, maybe even a month, just to gather data, do your regular pattern, learn what makes the numbers spike, learn what helps bring it down, and then just, take a step back from it. Like, you don't need to wear that all the time, so that you just educate yourself and then use that information moving forward, so that you're not feeling like it's something where you're constantly, looking at it and, if it makes you feel, overwhelmed or stressed. So I think that's important. And then the other point I just wanted to make about the CGM. So as Denise mentioned, it is measuring interstitial fluid. So it's not measuring blood. And so one thing that, sometimes patients will not realize is that there is a bit of a difference between, because there is a delay in the sugar readings that are coming in from the CGM compared to if you were to do a finger stick. So, I always tell my patients, especially those with diabetes, type 2, type 1, who are on insulin or otherwise, if you ever feel unwell and it's not, the numbers on the CGM aren't consistent with how you're feeling, you should always check a finger stick, because it may be delayed or it may be not exactly accurate. So always trust, your body at the end of the day, basically.
So that's a great point about having the ability to check your finger stick as well as your CGM. And so like, it's not an either or. Like, if we're trying to get you a glucometer, it's good to get the glucometer. And if we can get the CGM covered, great. Or if you want to buy one on top of what your insurance covers, great. But it's important to have both, or at least a glucometer, which is our like old trusty and tried and true friend. One comment in the chat here was that one of our attendees has a friend who has used the Stello, and the person's A1C went from 8 down to 6 in 3 months by using the Stello and understanding what their blood sugars were. And this is a person who does not take insulin. And the price was $99 a month. And then we had a question in the Q&A asking about pumps. Are pumps only for type 1 is the question.
No, the pumps can be used for type 2 as well. Usually these patients have a long duration of diabetes. As you may be aware, diabetes is a chronic condition and progresses. So by the time the patients are diagnosed with prediabetes, they've already been pre-diabetic before, especially patients who don't come routinely to see the doctor. So you lose about 50 to 60% of the cell-produced insulin just being pre-diabetic, maybe more. And so you already start losing a little bit of insulin, then the glucose starts going up, and then you become diabetic. And then by the time you become diabetic, there's a lot of data on that. There's a delay in intensification of treatment. So we first do, maybe oral agents, maybe now we have great medications like GLP-1 to help with weight loss if the patient has unhealthy weight, to minimize, because before, if the A1C was above 9, we just push insulin. Not anymore. We're barely giving insulin for type 2 unless there's a need. Now, over time, if the patient's been diabetic for 15 years and they have not been well controlled, they eventually have some degree of insulopenia. So they have not enough insulin to make it up, and they need to be on insulin eventually long-acting first and then prior to the meals, because they don't have enough insulin secretion just because of the duration of diabetes, and more so if it has not been well controlled. So those patients could be a very good candidate for the pump. So we do have some type 2 on pump therapy. And now we have also patients with significant insulin resistance that they have to use an insulin that is 5 times stronger than the regular U100, like U500. And sometimes we have to use insulin pump on these patients because they require more than 1,500 units of insulin a day. So with injections, sometimes it's almost impossible to get it. So we just, we could use the pump. But yes, it's for type 1, but then type 2 who do not produce insulin anymore, and they're on 4 injections a day.
This is reminding me of what do primary care doctors treat and what do endocrinologists treat. Dr. Tarek, do you want to take that one? Like where do we kind of decide what we're comfortable with?
Sure. For me, as a primary care doctor, as a general internist, I'm very comfortable treating type 2 diabetes, right? And for the most part, with counseling, with, medications, even starting insulin, those things come pretty straightforward. But I want to take a moment and just say, for all of you diabetics out there, I want you to give yourself some grace because this is hard. This is a chronic condition that requires vigilance. And the fact that y'all are here and trying to learn about things is really kudos to you, because I know, speaking from experience, it's really challenging. So for the most part, for us in primary care, we're pretty comfortable taking care of type 2 diabetes, managing it long term. I usually turn to my endocrinologist colleagues for all of my patients who are type 1. I definitely want them because it just takes more care coordination. It takes more of the details of using the CGM and the insulin pump. And that really requires a specialist. And so that's for sure. And then there's a significant percentage of my type 2 diabetic patients where I realize that, the care that I can provide is good, but I really want them to have the optimal care with the most team members there to really help. If they're refractory, as Denise mentioned, if they really, I really cannot help them get their hemoglobin A1C to goal after about 6 months of trying, or then I will, call on my endocrinology colleagues to help out. And I find that has been immensely helpful in those cases. How about you, Natasha?
Same. Yeah, the same. Sometimes, certainly anybody who's kind of getting recalcitrant where there's just like huge doses of insulin, and then you really know that something better is out there, whether it's, I didn't even know U500 exists. I thought there was U200. So there you go. No, there's an example in the deficit in my knowledge. So, and then some people with particular comorbid conditions where, each person is an individual, but sometimes when there's a few things that we're managing at once and I just want a lot more attention to the blood sugars, sometimes there's also metabolic syndrome with lots of lipid problems as well. And then we're kind of putting a few heads together to try to decide what's the best way. Once we get the sugars under control, that's first. First, control the sugar, then control the cholesterol, and weight management is often a piece of that, but not everything. So yes, and then there are a few people who are just they're just a little bit different than what you're expecting. And when something doesn't work the way it's supposed to work, and we're supposed to be quite comfortable with type 2 diabetes, we see it all the time. As Dr. Tarek said, like give yourself some grace and also just realize you're in good company. Diabetes is so common. We have so many people having amazing, wonderful lives, and they have diabetes. And it doesn't change their life. They just have, I mean, it does change their life, but they're still enjoying everything, and they have a full, wonderful life. When people like in their 80s and 90s that were taken care of that have had diabetes for a while.
Yeah.
We did want to talk a little bit about what happens when people do not have well-controlled diabetes. And as we were preparing for this, I think we wanted to highlight by the endocrinologists some of what we're avoiding. And I think that's so important. And sometimes I feel, even as a doctor with a couple of decades of experience, what I didn't see until I saw it later, like it makes such an impression when you finally see those side effects. We learn about them, but when we realize, oh, this is what we're preventing, then it really drives it home. And so we want to be able to help you understand how exciting it is to prevent this stuff. Like you can, with good care, you can prevent the potential side effects of diabetes that is not controlled. Do you two want to take that one?
Yeah, absolutely. So, I think that's one of the hard parts about diabetes, right? Is, you may not feel symptoms necessarily. Sometimes with high blood sugar, some patients are symptomatic, but others are not. And so, you really are sort of, taking what we say that, there are potential risks and complications to uncontrolled high blood sugars. And so, some of the things that can happen are, there can be damage to the eyes, so something called retinopathy to the vessels in the eyes. And this damage can, if over time blood sugars are not well controlled, lead to blindness. So that's probably, the most dramatic, but some patients can have, different varying degrees of abnormalities with the eyes and blurry vision and things of that nature. So that's one important complication we're trying to prevent with keeping those blood sugars well controlled. And obviously important to make sure that regardless of blood sugar control, and regardless of whether you've had any eye conditions as a result of diabetes, that you are seeing an ophthalmologist or an eye doctor for an evaluation at least once a year. If you have any complications or any concerns, then they'll usually recommend more frequent visits. So that's very important. Other complications probably are things that some patients have heard of. So things like cardiovascular disease. So patients with diabetes have a higher risk of things like heart attack and stroke. And then other vascular issues, including problems with the vessels in their legs. They might feel pain when they walk or have other discomfort. And burning in the feet might be, or pain in the feet might be a result of damage to the nerves in the feet. So that's something called neuropathy, that patients can also experience if they have higher blood sugars. And then lastly, kidney dysfunction. That's not last, but one of the other big ones I think that, a lot of people have heard and, we are working to prevent is complications where there's damage to the kidneys, leading to, abnormal kidney function, and eventually it can cause some patients to develop kidney failure and require dialysis or transplant or treatment. So, we see all sorts of these conditions and complications on a spectrum, but obviously our main goal is to control the blood sugars and never see any part of these sort of complications for patients. But, these are things that we make sure to monitor for, so when we're doing exams, we're examining and trying to evaluate for these complications, making sure patients are seeing the right specialists if they need to, doing the appropriate blood tests. Like in the case of kidney dysfunction, we're checking urine protein tests and blood tests as well to make sure that we catch any early signs of these diseases. So that's just some of it. There are many other complications that I didn't mention. I don't know, Denise, if you want to touch on that as well, but it's really important to keep the sugars controlled for those reasons.
I think one important point is that diabetes is considered a cardiovascular risk equivalent. 1 out of 4 patients with diabetes could develop congestive heart failure. The duration of diabetes increases cardiovascular risk, and I've seen that over and over, and I can give many examples on that, but patients who've been diabetic for more than 20 years, even well-controlled, has significant cardiovascular risk. So not to scare you, but it's a good idea to check cholesterol. And the cholesterol, the bad cholesterol, the target should be based upon findings. So now we have more data to assess, okay, what are the further cardiovascular risks the patient has. So there's a calculator online that I use a lot. This cardiology use that all the time, but I learned that from cardiologists. And so this calculation determines risk, right? So if the risk is less than 5%, and this calculation based on age, so it's 20 to 79 years of age, 71 or 79, I can't remember exactly. Female, or male, the age, if the patient is a smoker, if the patient has been on aspirin, if the patient has taken statin, if the patient is diabetic or not. So when you put all the data into that online calculator, it's going to give you a risk, 10-year risk for getting a heart event or cardiovascular disease. And if the risk is less than 5%, then it's low risk. 5 to 7% is intermediate risk, moderate. Then more than 20% is very high risk. So I have had patients with diabetes for 40 years, type 1 or type 2, that they have a perfect normal LDL. And then I check the cardiovascular vascular markers like Lp(a), which is in now, high sensitive C-reactive protein, and they're super high. These patients sometimes are very active. They don't have any symptoms at all. They can pass a stress test, very likely. And it's hard to just send to cardiology for those stress tests because they're going to pass. I mean, they exercise every day, but then you do these markers are really high. So that patient, I send him for a calcium coronary CT, especially if the patient has not been on statin, because there's a lot of hesitancy of being on statin. And then I found very high calcium coronary score. So this test actually measures percentage of calcification on the arteries of the heart. And the score goes from 0 being normal to 100 being mild plaque formation and 300 being very high. So the risk, if it's 300 or 2,400 or 16,000, it doesn't matter. More than 300 is high. So the number really doesn't mean that it's the higher the number, the worse it is. 300 above is high. And these patients have significant cardiovascular risk. So I've had patients who have an LDL of 88, very high vascular markers, positive calcium coronary score. I treat them. So you bring the LDL down to 55 because that reduces plaque formation. Now, there's patients who have been diabetic for less than 20 years, and they have an LDL, we try to keep the LDL less than 100 on diabetics, but if they have had history of cardiovascular disease, maybe less than 70, but if they have a lot of plaque in the calcium CT, it's 55. So we're being very aggressive in these patients because we know, the first cause of death in US is heart attacks, right? And so, and we know that the diabetes is a cardiovascular risk equivalent, and that's the same for type 2 and type 1. So we try to stratify risk. And on somebody who's 30 years old, diabetes for 10 years, I don't worry so much because age is a risk factor as well. But I do, I tend to be very aggressive in my patients that are a little bit older, not old, but, after age 40, I start getting a little bit concerned and be a little bit more, aggressive in terms of LDL or cholesterol lowering agents because it does reduce risk. So I think that's something that we check. As endocrinologists, we all the time, we check lipids at least every 6 months on patients who have a little more risk. Most of the patient has comorbidities like sleep apnea, hypertension. They have strong family history of heart conditions. So
Yeah, that's
Thank
so
you.
important, I think, to just realize like that should be the number one thing I think that we're aware that we're raising everyone's awareness because everyone understands heart attacks. They want to prevent heart attacks. They may not understand retinopathy. Um,
Right.
sorry, did you have a couple other things to say?
I was just going to add that there's quite a few questions coming in, which we're really grateful for, and I want to make sure that we get through them and make sure that it's answered. So the first one is there any promising research that in the long run may lead to a cure? That's the first question.
for type 1 or type 2?
So the next, it may be type 1, I'm thinking, but then the next question is type 2 diabetes reversible? So there you go. So you might want to answer for both.
So you want to jump in, Dr. Sacha? You want me to talk?
Yeah, so yeah, I mean, for type 2 diabetes being reversible, I mean, so we do see with, we know that weight gain or obesity is often linked to type 2 diabetes. So with weight loss, we can see improvement in blood sugars. We can see that numbers can come down so that patients can get off medications. It depends, I think, on duration of diabetes for the most part. If someone has had diabetes for a very long time, even though the numbers get better and they may be off medication per se, they'll still see some degree of insulin resistance, meaning that when they eat things that have high carbohydrate load, they'll see that the numbers can go high. So, we do also see that there's a subset of patients that they'll have, surgery, bariatric surgery to, lose weight. And we can see that there is remission of diabetes in some of those patients. We do see that, diabetes can come back if they regain weight. So, I think it's almost a complicated answer because diabetes is a chronic disease. And even in those patients that we do see remission of diabetes temporarily, sometimes it does recur. But to improve blood sugars, to actually achieve, reversal, the one of the main goals for many patients, especially, and this is specifically type 2 diabetes, is weight loss. So losing weight can really help you achieve that goal of decreasing medication burden and hopefully keeping that A1C in the normal range or, lower. So that's really the goal.
Thank you.
Yeah.
And did either one of you want to make a comment real briefly on a cure for type 1 if the person was referring to type 1?
I think there has been a lot of research on this topic, and actually there is no cure yet. They have done islet cell transplant for many, many years. And what I've seen in these patients is that for 3 years, maybe, the patients do not need to be on insulin, but they have all the side effects from immunosuppressant therapy. So it's kind of a trade-off, right? On the type 1 that is late onset diabetes, which is very similar to type 1, but the onset is a little bit more insidious. There has been medications, I think it was teplizumab, that they're studying for the phase 3 that slows progression of disease, but no cure. So I don't think we have gotten yet to the point that we're going to say cure, but I think it's promising. I mean, we are in a much better position than we were when I was doing my fellowship years ago. So back in 2007, there was 3 types of insulin: NPH, regular, and Lantus.
Yeah.
I mean, now we have 5 different types of like short-acting insulin. We have ultra long-acting insulin, 2 different types. We have great insulin pumps. We have the CGMs. So certainly the technology to allow a much better quality of life for these patients. I remember seeing my patients in the clinic with little tiny holes from pricking themselves 7 times a day before. It was awful. So we do not have a cure yet, but there's been a lot of research on this, and I am hopeful that eventually we can come close to say, or at least to help patients. But, it's a long way. I don't see that anytime soon, unfortunately.
Yeah. Thank you for that. There's another really good question that kind of leads to prevention as well. Is a high triglyceride test with a normal cholesterol necessarily a risk factor for a high A1C for diabetes?
For a high A1C, let me read the.
Yeah, I think they mean like
Oh.
for diabetes. For is high
Oh.
triglycerides with a normal cholesterol. Y'all, if I'm missing the point here, please correct me. But I think that's what this question is referring to. Is a high triglyceride test with a normal cholesterol a risk factor for diabetes or an elevated A1C?
No, I mean, it's sort of a separate problem. They all can go together in the sense that patients who have abnormal cholesterol, triglycerides, impaired or abnormal blood sugar, these conditions tend to coexist in the same patient, typically because potentially of lifestyle or genetic predisposition, but one is not necessarily, I would say, a risk factor for the other. Well, at least the triglycerides specifically making the A1C higher. But I would say that just and I wasn't sure if they were asking about triglycerides itself. I would say that, even if the cholesterol panel, like the total numbers is normal, I do look at the individual numbers. That's really important, right? So I do look, and if the triglycerides are above 150, I sort of still consider that an independent risk factor. If the LDL value is above the goal for that patient, I consider that an independent sort of risk factor that I want to try to reach at the target that we know is important to keep patients at who have a history of diabetes to reduce the risk of cardiovascular disease. So I'm not sure if that's what they were asking about.
I
I would
think
also
that
add that there are times when people come in and their blood sugar is a little high and their triglycerides are a little high.
Right.
And when they start eating differently,
both come
and
down.
this can be actually pretty high. Like you could have triglycerides like in the 450 range, 500 range. Maybe your A1C is only 7, but you start working on it and your blood sugars come down, or just weight loss itself, the triglycerides come down at the same time. So it's not like one is a risk factor for the other, but maybe both have the same predisposing
They
factor
do.
that
So, right, exactly. Because we know triglycerides are made, part of the substrate is carbohydrates. So, one of the main things that I tell patients, especially those who really, really high triglyceride levels that might put them at risk for, things like pancreatitis, we tell them to reduce carbohydrate intake. While that will also reduce blood sugars, that will reduce triglycerides as well. So, absolutely.
Yeah, thank you. The last question is, I have neuropathy with my type 2. The bottom of my feet frequently hurt and it feels like I'm walking on rocks. Any guidance on the type of shoe I should wear, or are there shoe companies I should consider or avoid?
I'm going to give you a tip that has worked for my patients who have neuropathy. And it's just a recently discovered because I had this patient with a very unusual type of diabetes, and she was seeing this endocrinologist at UVA, and he recommended her to be on alpha lipoic acid. And so I'm not a big fan of doing a lot of over the counter unless there's a strict necessary need for example, vitamin D or baby aspirin or, sometimes vitamin C. But she swears by alpha lipoic acid. So I started doing a little bit of research about what is this about. And then a couple of my patients with painful neuropathy, I started to recommend, alpha lipoic acid between a dose of 300 to 600 micrograms a day. And every single patient have told me that the intensity is much less and it's more manageable. Now, I do have a patient who had history of neuropathy from chemotherapy that didn't work on her. But on my patients with diabetes, I think maybe worthwhile a trial. I think in terms of diabetes shoes, depends, if you have calluses that are prone to get ulcers because you're not feeling your feet or your floor when you walk. I mean, we usually send to podiatrists because the callus need to be shaved and to look for underlying ulcers because these patients usually do not feel, right? So that's the problem. When you don't feel, you can step on something, hurt yourself. So always wear shoes and socks. When you go to the beach, wear like closed shoes. I think the shoes are more based on the examination from the podiatrist, but you could try alpha lipoic acid, which has been wonderful for my patients. And I'm talking about patients who've been diabetic for a long time, not just new onset diabetics. Usually they don't tend to get neuropathy, but my type 1 and type 2 that I've recommended has been really useful for them. So you can give that a try, but maybe you may consider seeing a podiatrist for, to see what type of shoes you may need, because it's kind of broad to suggest something, because depends on what you have on your feet,
Didn't know that trick. That's a good
Yeah.
one to learn about.
Yeah, I've been recommending that for my patients as well. And I would say it hasn't worked for all of my patients, but I totally agree that it is definitely worth trying, because it definitely does help some patients.
Mhm. So we're over. It's 8:05. I would like to ask two more questions, and maybe, sorry, you might have another two, and let's wrap up within the next couple of minutes. If you have any last burning questions, please put them in. One is, could you give your 2 cents on the keto diet? And two, can you tell us the latest recommendations for aspirin?
Yeah, so I can take the keto question. So, I think again, it's all individualized, right? So it depends on the patient. If we're talking about a patient, for instance, with type 1, I tell them no, because keto technically means you're doing less than 50 grams of carbs per day. And I just don't like the concept of being super low carb if you have a certain type 1, or to that degree, I should say. For type 2, fine, if you want to try it, it's okay. I think I generally don't recommend that for my patients. I mean, one thing I didn't mention is I am obesity medicine certified, and I do discuss diet with patients. And I think the hard part about keto is that it's not sustainable for most people, right? And when we're talking about the word diet, we're talking about something that you want to be sustainable, because really it should be like a lifestyle change if you want sustained weight loss. So I don't love keto, because it really, to me, is just like a short-term thing that most people don't stick with. So I'd rather patients really focus on macronutrients, focus on getting your protein, focus on getting your fiber, focus on, eating healthy carbs and making that a minimal amount of what you're eating, so that, you can maintain whatever diet you want to do to maintain your weight loss long term. So I don't love it. Yes, patients will lose weight quickly, if you do super low carb, but it's just, what happens is as soon as you stop it, patients regain, and that's just because you're not doing that type of, calorie restriction.
Sometimes we see patients not knowing what are the good fats. And sometimes we see this patient with significant elevated cholesterol levels on the keto diet, like 300
Yes.
LDL. And so, so I think if you're going to do a keto diet, you have to be careful what you choose. So
Yeah.
the only diet that has been proven that has helped reduce cardiovascular risk is the Mediterranean diet.
Mhm.
And that's a diet I recommend. I do not recommend very low carb diet. I don't recommend extreme diets. I don't think they work. In fact, I don't even tell the patient this diet. I tell them lifestyle changes, because it's not like you're going to diet for 3 months and then nothing's going to happen later on. So it's just, you have to change the way you're eating lifelong, the way you're, following physical activity, exercising. You have to put a mindset that this is a lifestyle change. It's not a diet. So I just try to stay away from diet, but the truth is Mediterranean diet, what it's called, it's a very great source for patients to follow, because they have very lean meat, right? Lean protein. They can drink a little bit of wine with moderation. They do have tons of vegetables. They do have fruits, drink plenty of water. And, what is interesting about Mediterranean diet is that they have found that these patients living close to the Mediterranean, they live longer, and they found that they actually sit down and enjoy the meal. So these patients don't eat in a rush and then just go again back to work. They actually sit down for like half an hour and enjoy the meal and, talk to, friends. But, I think this is the only, well, it's the main one that I recommend for patients if they tell me what do you recommend? And then low salt for patients who have hypertension, or DASH diet, dietary action to stop hypertension. In terms of the aspirin, I know what you're referring to. So baby aspirin was given in the past as
That's exactly what I was asking. You got it. Yep.
And we have one final question. I have type 2 and stage 4 kidney failure. Does the kidney condition have an impact on the accuracy of my blood sugars?
It can. It depends. So CGM data may not be quite as good. I would also say that the hemoglobin A1C number is not as accurate. So really the finger sticks are going to be the best here because unfortunately, many patients who have chronic kidney disease, including those with kidney failure, will have some degree of anemia or low hemoglobin levels. And as a result, because our hemoglobin A1Cs are measuring glucose attached to hemoglobin, the less you have, the lower the A1C will look. So the A1C may look falsely better than it actually is. And so that value isn't quite as accurate. Sometimes we'll do other tests that might be a bit more accurate. But the finger sticks are really going to be the best measure there.
Thank you.
Well, thanks everybody. This was really, really fun to talk to you. I'm really happy to get to do something collaborative with you, Denise. It's been years, and Ramona, super nice to meet you. And I'm extremely excited to be working with Sarah for hopefully the rest of my life. So great to have all of the attendees here, and thank you so much for contributing questions. This will be up on our website maybe in a week or so. It might take 2 weeks because the person who does that is not working full time right now, but great to have everyone, and I'm gonna call it a night. Good night, everyone. Great to see you.
Thank you.
Having us.
Okay, thanks so much, Denise. Thanks, Ramona.
Thank you.
Bye-bye.